Welcome back to the Team LocoFit Roundtable. I'm your host, Laurin Conlon. Each week, we share the evidence-based practices and communication-driven strategies we use with our clients to help you look, feel, and perform your best. This week, I'm doing an interview with my friend Taylor, and I'm so excited. We're actually at First Form headquarters right now, and we are going to be talking all about pelvic floor health, which is definitely a misunderstood and really not talked about enough type of a topic.
Definitely.
So give us a little bit of your background, Tay, and then we'll go from there.
Perfect. Hi guys, thanks so much for having me on, Laurin. I really appreciate it. I'm excited to talk to you all today about pelvic health. So my background is I am a doctor of physical therapy. I graduated 3 years ago from Washington University in St. Louis. Got my doctorate, and then I worked at an outpatient orthopedic center. Was not the right fit for me. I was seeing 3 people an hour, average of 70 patients a week.
Oh shit, 3 people an hour.
Welcome to healthcare in the US.
Yeah, well, yeah.
So I knew that because I went to this amazing school, I did not want to continue to provide that quality of care. So I opened my own private practice out of a sports performance gym here in St. Louis. And then I actually also see people here at First Form. So kind of a mix. I really specialize in, I would say, the athlete realm. I also do postpartum, a little bit of pelvic health, and we'll kind of get into the difference between a pelvic health therapist and just a normal PT here in a little bit. But yeah, that's my background.
Yeah, that is, there's so many things that we could talk about with the healthcare system. But it really is crazy how it's pushed through, whether it's PT, whether it's mental health, doesn't matter what it is. It is such a, I don't really know what the name of the model would be, but just so many people per hour, and you really can't be expected to give good care. We've talked about it before on this podcast, but with psychiatrists, a lot of them, unfortunately, if you're in that model, you're seeing people for 10 to 15 minutes. And what are you really going to be able to do in that time?
Exactly.
Obviously to diagnose somebody with anything, or to talk with them about what's going on. And same thing with you, what are you really, maybe a follow-up, a quick, hey, how are things going? Check in, but not the majority of your how long would you say that most of your sessions are? About 60?
Since I went out on my own, I do one-on-one evals are typically about 75 minutes because you have to do the full assessment, and then reevaluations or follow-ups are typically 60 minutes too. I do offer 30, but for the most part I'm doing 60 minutes. And kind of going back to what you said, our healthcare system is like a factory. It's how many people can you push in, how many people can you get out in X amount of time to bill X amount to insurance. So I actually only do cash-based now. I'm considered an out-of-network provider, so we can submit to insurance after the fact, but I don't do insurance anymore because insurance likes to dictate how much I can see my patient and how much they're going to reimburse. So kind of a nightmare.
Yeah, pretty much every person that I see is a cash-based business, and that's the reason, you know what I mean? They actually want to give good care, and it's yes, this is expensive, but that's, if you want to, it's the difference of going to PT and actually seeing changes versus going to PT and being oh, this didn't work.
Right.
Do you want this to actually pay off? So you're probably going to need less in the long run, you know what I mean?
Exactly.
If you actually do this the right way.
I even talk about that on my website. So the typical, at the previous place that I was at, that was more of a corporate location, I was seeing people on average 2 to 3 times a week, and that was pushed because the doctor wrote a script and insurance says they need to come 2 times a week. My model now, I typically only see people 1 time a week or even do bi-weekly sessions unless it's somebody that's post-op. So you're going to get better faster because you're getting one-on-one care, which is the big overview.
So, okay, enough about that. I'm we could do a whole podcast
on that.
Whole
Don't
podcast
even get me started
there. But what is your pelvic floor? I feel people now are talking more about it, but what is your pelvic floor?
So ironically, it's funny, I was telling a patient this the other day. In Europe, you get referred to a pelvic floor specialist right after pregnancy. It's a thing, right? Postpartum. In America, not so much, right? You go to the doctor, you've had your cute little baby, 6 weeks go by, you go back, everything looks great, go back to working out, and you're okay, what does that mean? How do I do that? Can I start running right away? So there's still not a big push to refer out, which is sad because a lot of women are in this space where, okay, some things hurt, should I try this? What should I not do? Which is where your pelvic floor physical therapist comes into play. And when we get into anatomy, your pelvic floor is basically like a hammock, okay? It's going to support your internal organs. It's going to stop urine and feces from coming out. So it's really an important player, and it's closely related to your lower abdominals. The big three muscles that we kind of combine are called your levator ani. I'm not going to go into too much detail for you guys, but again, just think of a hammock that's kind of sitting there. Some people say a dome-shaped muscle. I like to call it a hammock, and it's there to support everything.
I like the hammock analogy. Yeah. that does make sense. Like that's just like a perfect little hammock. So what would be some signs of pelvic floor dysfunction? Because that's obviously what we're hearing most about. Right. It's not like, oh, my pelvic floor is great. We're hearing about it in the sense of like there is some type of dysfunction.
Yeah, totally. So that can be very wide range. Your pelvic floor is closely related to your lower abdominals, like I just said. So it can present as back pain, hip pain in terms of orthopedic, and then typical complaints with pelvic floor dysfunction are going to be things like incontinence, leaking when you cough or you sneeze, or maybe you're somebody that's working out and you're doing heavy lifting and you're getting leaking there. Maybe it's with running, maybe it's with jumping. Pain with sex is a really common one. Issues going to the bathroom, so sometimes constipation, that can actually be treated by a pelvic floor specialist. Just bowel issues in general, so it's really wide range. I would say the most common that we see is going to be stress incontinence and urge incontinence or stress frequency, where people are complaining of leaking or they're having pain with sex or issues going to the bathroom. That's going to be kind of your top three.
Yeah, man, and that's like kind of like, that would maybe seem like a lot of different problems, right? You know what I mean? Like not necessarily like, oh, pelvic floor. Right. That could be like, oh, well, maybe it's this, that, like hormone changes or this or whatever. So that's good to know.
Yeah.
And I think the big one is that a lot of people are curious about how to engage this properly with training, so that we don't maybe make things worse or even create problems. Or is it something that like you're not really creating, it's kind of like already there? Like how does that all, like how does the dysfunction start, I guess, and then how does training make it worse or better? Yeah.
So dysfunction can start, I mean, obviously the most common is going to be after childbirth, right? Postpartum. I was actually looking at a study the other day. Most of pelvic floor dysfunction actually comes from vaginal births, which makes sense if you think about it, versus like a C-section birth. It can start in more of the lifting population. So most people also think of pelvic floor dysfunction as also just being postpartum, and it's not. I actually have a couple patients now that have pelvic floor dysfunction and they're just lifting weights and they've never had kids before. So typically with something like stress incontinence, you're unable to kind of coordinate your intra-abdominal pressure with your pelvic floor activation in your lower abdominals. So biggest thing is going to be breathing. Kind of day one is what I go through with everybody, even if they're not having pelvic floor dysfunction, but I can go into that a little bit later. And then I also see it too, even like down the line. So if you've had multiple kids, you're going to be more prone to pelvic floor dysfunction as well.
Okay. So then with training, obviously breath work, let's go into that, because I think a lot of people really don't know how to breathe. A lot of people are obviously going to be like big chest breathers. They're not really going to know how to like diaphragmatically breathe. So let's go into that and then where that would play into training.
So with training, things that can make it worse are obviously going to be continuing to lift heavier loads. Like you may be somebody that has leaking when you're squatting 250 and you're not utilizing that diaphragmatic breath, which I'll go into next. So that's kind of the biggest thing, is continuing to do overloading and overloading your system and not being able to connect your pelvic floor with your diaphragm, for instance, in your lower abdominals. So with diaphragmatic breathing, I always, like I said, I teach every patient this, whether it's a low back patient or even somebody with an ankle sprain. You need to learn how to breathe if you're going to be lifting loads. Biggest thing that I see, especially postpartum, you have to think like after you have a baby in there for 9 months, that space is going to expand and your ribs really can't expand at all, right? You're stuck kind of breathing through your chest. And most females, even if they've worked out in the past or even if they're currently working out now, they tend to do kind of like a paradoxical breathing, where instead of when they take a deep breath in, their stomach actually sucks in instead of going out. So when I say diaphragmatic breathing, as you take that deep breath in, we really want your diaphragm and your belly to expand out like a balloon. So think of if you're laying on your back, you want it to expand towards the ceiling. Now with that also comes rib cage movement. So we have pump handle and bucket handle movement of your rib cage. So it's really important to kind of make sure that all of those things are working together. And then I also look for people especially if there's somebody that's a really big chest breather, which is more common in females. I mean, think about it. Society, we're used to sucking everything in all the time. We're not taught to breathe through our stomach and let everything out. Like, why would you do that, right? Why would you have a big belly while you're trying to breathe? So that's kind of the hardest thing, I think, to teach. You might look pregnant for a second, but it's fine. I promise it works. So yeah, that's the biggest thing, is kind of getting that diaphragm, which we know actually attaches onto your lumbar spine. So it acts as a stabilizer, and it's closely related with your lower abs. So getting that to expand as you take a deep breath in under a heavy load, and then you have to come out of that too. So you have to be able to engage your lower abs, exhale, and kind of pull in your transverse abdominis, your internal oblique specifically, as you're kind of pushing up that load. So for instance, with a squat, you're going to take a deep breath in, you're going to let your belly out as you descend, and then you're going to exhale, pull everything in. So simple cue, belly button is fine, but then getting your rib cage stacked over your pelvis is really important as well.
Yeah, and it sounds easy, but it definitely is very
coordination.
Yeah, it is and especially if you are used to lifting heavy, you're probably going to have to maybe make some adjustments while you're first learning to do this. And even just so I just did an interview with one of my friends on like meditation and mindfulness, and we were just talking about like, honestly, the power of just sitting for like 5 to 10 belly breaths, whether you're sitting or you're lying down. And like, people often think that like, when you want to start engaging in something like mindfulness or meditation, like you need to like, be like, legs crossed, like incense, like, this whole like hour-long thing. It's like, no, literally just like take a few breaths for a few, like just a few, and then just see how much better and like clear-headed you feel. And if you do that twice a day, like some people don't even give themselves that minute, you know what I mean, to like just sit with their thoughts,
be still.
So sometimes like it can be really useful for not just training, but especially in the context of pelvic floor, that is going to be really, really important. So we did get a lot of questions, of course, about pregnancy, and one of the main things people ask is how to prevent DR during pregnancy. And I don't want to mess up how to pronounce it, so you can go for it.
Diastasis Rectus Abdominis.
There we
DRA,
go.
for sure.
There we go. I was going to say something sort of close, but we're here with the professionals. So how do we prevent DRA?
So I'll first explain kind of what it is, and then talk about how common it is. So statistically speaking, pretty crazy, but kind of 1 in 2 women might develop DRA postpartum.
1 in 2.
It's really common.
Very common.
I always try to like tell my clients it's going to be okay, because everyone's freaking out. Do I have DRA? Or my abs split? Can I get it back together? Take a deep breath, like we just talked about. Sit there for a couple minutes. It will be fine. It's super common. It happens belly breathe, please. We'll go back into that again. Big important key today, belly breathe. So what happens is you have your rectus abdominis, which is your six-pack muscle, and between that, it's in 2 sides. You have the left and right side to that. So you have something called your linea alba, which is basically this connective sheath that holds it together. Diastasis rectus, basically, it's more common to develop in the 2nd and 3rd trimester of pregnancy. Sometimes I see it in people that aren't pregnant as well, who suffer from not being able to control that intra-abdominal pressure and use their abs appropriately with weightlifting. I see it in men too. So just a heads up, men, you can also see a pelvic floor specialist as well. But going back to that, so it's really common, like I said, 2nd and 3rd trimester. What happens is over time, obviously, as baby's pushing on your uterus, it's going to stretch that linea alba, or that sheath that connects your 2 sides of your rectus. So a nice, easy test that you can do postpartum, I recommend everyone see a pelvic floor specialist or even just a physical therapist to kind of get back to activity. You can do a small crunch. So you're going to lay on your back with your knees bent, and then you can take 2 fingers and you can start either above or below your belly button and see if, as you come up and crunch, if you're able to fit 2 fingers in that little gap. So the goal is 2 fingers or less. Okay. So you're on your back, you're doing a small like crunch, sit up, your feet are bent, you're in hook lying position, so knees are bent, feet are flat. Do your crunch or sit up and you see if you can fit 2 fingers. We like to see 2 or less. So if you have 3, that's indicative of DRA or diastasis rectus. That's kind of the big thing.
And so there's probably not really a way, or is there a way to help prevent this during pregnancy?
There is, which is doing the correct core work and doing good breathing work too. So can't emphasize breathing enough during pregnancy and actually doing that diaphragmatic breath. So I tell especially my moms that are postpartum or even early on during pregnancy, it should be gentle. A lot of times when people are first starting to learn that diaphragmatic breath, they feel like it has to be super forceful. It does not. It's a nice, easy inhale. You can use your hand as tactile feedback. I like to start moms, obviously after the first trimester, you cannot be on your back for supine or supine for a long time. So I like to start them in side lying, which is actually kind of an easier way for you to feel your belly expansion too, because you're in a gravity lessened position. So it's good to kind of start in side lying, learn that diaphragmatic breath well, and then you can convert up into sitting and standing, because that's kind of I like to take people from the table up to upright position.
Nice. Okay, so there is a way to prevent it. That's good
Yes.
to know. And that's where, having a specialist would be really useful.
Correct. Do's and don'ts, no sit-ups, no crunches, number one thing.
Yeah.
I tell my moms,
gosh.
and even postpartum, the first 6 months, I don't like people doing sit-ups and crunches, because what it's going to do, it's going to exacerbate that DRA if you do have it and it's present.
Yeah. People talk about that, like the coning that happens.
Correct.
Like that would basically
Yeah, so that's part of it.
Yeah, and that can happen too, like when you're not necessarily pregnant,
Correct.
right? So
Yep.
that would be
Exactly.
a test to see if maybe things aren't like working synergistically. Maybe that you don't have DRA, but maybe that things just aren't working.
Yeah, there's not that
properly.
motor control there. Connecting the
So
two.
what would be some of the best core exercises to do during pregnancy, and also just not like just in general, like your recommendations for core training?
Yeah.
Core training.
So during pregnancy, like I said, after that first trimester, you can't really be on your back. So we're working a lot in side lying. And then one of my favorite positions to work on core training is actually in quadruped or hands and knees. Like I said, pregnancy, you're not going to do sit-ups, you're not going to do crunches. As you get bigger into that second and third trimester, you might not be able to tolerate hands and knees. You might notice that coning because gravity is pushing down on you. So you might really just be working kind of in the side lying position and even standing or sitting. So a couple of my favorites are going to be lower abdominal strengthening exercises. So little anatomy. We have that rectus, right? We peel that back. We have our deeper layers. We have our external oblique, our internal oblique, and our transverse abdominis. So those are kind of your deeper core muscles that you really want to work on both during pregnancy and then immediately postpartum as well. They're the harder ones to get, but they're also the closer ones to your spine. So they're going to help stabilize your spine a little bit. So really important with moms that are having back pain, or even during pregnancy if you're having back pain. Biggest thing with that transverse is just getting you to actively pull your belly button towards your spine, and that's going to allow you to kind of activate those deeper core muscles. And then I want to make a spin real quick into posture. With a baby in your belly for 9 months, you're going to obviously change things. Muscle length tension relationship's going to change. We like to call it the tuck butt or a sway back posture. So you get in this habit where you have this big load in front, so maybe you're really extended, or you get in a habit when you're breastfeeding where you kind of tuck your butt under. So number one thing I work on with clients is getting into a good posture, and that's going to involve getting your rib cage to be stacked over your pelvis. Number one, so that you can use your pelvic floor muscles, but also so you can use your lower abdominal muscles like we were just talking about. There's a whole series of lower abdominal progressive series that I really like to use with patients. It was actually developed by a physical therapist that was at WashU forever, so we got it ingrained in our heads. You probably have heard of it. Sometimes it's called the lower ab march, where you're on your back and you're lifting one leg up, then the second leg up into 90-90 position, and then lowering them down one at a time. So supine on your back, one up, second up, down, down. We call it up, up, down, down too, for short. It looks like it should be easy, but it is deceivingly hard if you do it correctly, right? So we call it no arching of the back or no back extension as you go to lift that leg up. You want to make sure you're not holding your breath, because that's also a common mistake that early on during postpartum or even while you're pregnant, we like to hold our breath as we're trying to do something that's challenging for our muscles. So making sure you're breathing throughout. I always cue to kind of exhale and pull everything in and get that rib cage nice and positioned over your pelvis. Then you can lift one leg up. And then the hardest part is when you lift that second leg up, making sure that your back doesn't extend and you're nice and stable.
Do you want to think about like pushing your back into the ground, kind of like a dead bug, or not as much?
Not necessarily. I don't like the cue of pelvic tilting either, because a lot of people are cued, could be by, a personal trainer or another physical therapist, to just tilt their pelvis backwards, but you're not actually engaging your core. So there has to be that intention of, okay, I'm really drawing my belly button into my spine. Your back really shouldn't move, right? So some people will make the mistake of they actually flex their back or do lumbar flexion.
Yeah.
And it's not the same thing as activating your core. So you really just want to be nice and flat. Your back shouldn't move into extension or arch, so no doming under that. You should keep contact the entire time, and then making sure you maintain that breath throughout.
Yeah, that does sound pretty hard, because
So
I'm thinking like when I'm doing it, I'm like, I'm probably compensating with my back.
Yeah. Yeah, and I'll have people like, I'll ask them, okay, where do you feel this at? I'll just let them tell me before trying to cue them. Oh, I feel my back. That's a no-no. So then we kind of have to take it a step further. So that level 1 is just that simple march. Sometimes I'll start even lower than that, where you just exhale, lift one leg up, put it back down, then lift the second leg up. So taking it down a step as well. Like I said, there's 5 different levels of this lower ab progression that I really like. Dead bugs. Yeah. Level 5 is really hard. I'll make Laurin do that this weekend and post it for you guys.
After like 3 glasses of wine, I'm like, let's do it. Just roll it around.
Just wait.
On the floor.
On Instagram. But those are my favorites, and those are going to be the ones that everyone neglects, right? I have people that walk into my office with 6-packs and they have back pain, but they have no lower abdominal strength, and they don't even know what it is. So that's really key. I like dead bugs. I like bird dogs because you're in that quadruped position, making sure though that there's no pelvic movement, and you're coordinating that breath work with it as well.
Yeah, I feel like with the bird dogs too, a lot of people, I'm not sure if you see this, but a lot of people get the leg, like the glute leg part right, but their upper body is like either like just kind of like down, like they'll bring their leg up and then their upper body is just like so slack. It's like, no, it's supposed to be completely straight. So if for that, they're really, really good, and they're not hard to do, but definitely video yourself if you know.
I was about to say, or use a mirror.
Yeah, because
visual
you will be so surprised that you're actually tilted like down, like your glute will be too high and your arm will be too low, and then it's really not like it's not a glute, it's not just a glute exercise. So if you're like, oh, I feel it in my glutes, you're like, okay, great, but that's not it's not the only thing. So
and it's good too to kind of just getting in quadruped and playing around with doing pelvic tilt. So going into like an anterior pelvic tilt, a posterior pelvic tilt, so you can find your neutral position. And I really like my clients to use mirrors because they can look over it and see, okay, is my back actually straight? Is it neutral, or am I a little extended? You know? And then even taking that bird dog exercise, a lot of times I'll just start with just hip extension, so kind of a step back to modify, and have them just work on exhaling, pulling everything in, and then pulling their leg out into hip extension. And that exercise, actually, there's a study done back in 2011. That was one of the best exercises to activate for glute max. For EMG studies.
Honestly, I love bird dogs. Like they seem like they're like, yeah, whatever, but like they really are great.
You do it right.
This is not just about pelvic floor, but a lot of our listeners will know that there's been a huge craze once again with vacuums. So what are your thoughts on vacuums? Do you like them? Do you not like them? Do you think most people do them wrong? Probably.
It's funny because like I think there's a time and place for it, obviously, like if you're a competitor, but I feel like they're done probably wrong. They can be beneficial if you were using it correctly, but you're not even doing ribcage movement with it, you know? It's more of just that belly button. I'm indifferent about it. I would say don't do it a lot.
Some people, swear by it. And again, I think that it's like anything. A lot of people probably, the people who are benefiting the most are probably doing it right. Correct. But then there's probably a lot of people who aren't doing it properly. So definitely, maybe, I don't know, that would be like a hint. Put out some good resources on that, because like when I first started bodybuilding, that was like the thing, because I have a very like blocky waist. I really don't have a waist. It's just kind of like a SpongeBob. So I was always told like you should do vacuums, like bring in your waist, and that was just kind of like the old school bodybuilding way of doing it. And then it kind of like went away, and then there's like been like there's always like resurgences of everything. Like there's like a resurgence like of that, just kind of like how like squeams will come in and out of fashion like every few years. Which are not good, particularly for what we're talking about. So they might have a small effect on your waist, but I can't imagine. First of all, it's transient. As soon as you stop wearing it, it's not going to stay. Secondly, the way that people breathe in those is so bad, and they're wearing them all day, super tight. They're training.
Can't use your belly at all.
No, they're training
diaphragmatic breath
in them. And then lastly, most people I see who use them, I can tell when I look at them, because they have a small waist, but they have this like, don't want to call it it's not, it's just like this, the lower abs like just don't ever look super tight and crisp, and they're lean people. It's not like these people have a lot of body fat to lose. It just kind of almost like accumulates and makes this weird shape, and I'm like, so you're trading off this tiny waist for now like this like lower belly like distension. It's almost like a distension, because it's not like it's not like a pooch, it's just like a
it's there. So that's where lower ab strengthening, though, like those specific exercises can come into play, and they're great for bodybuilders too, because you're probably not doing anything like that. You're doing your typical crunches, sit-ups, leg raises, whatever, you know.
Which can be great, but
there's a time and place for those. But
do need to have a well-rounded. Now, we did have some questions too on like kind of pelvic floor prolapse. So like, let's say you've gotten to this place where like, you know, things are not doing too great. What are some do's and don'ts? Some exercises to maybe incorporate or don't incorporate. Obviously, I know this is just general because you'd have to see somebody.
I'll talk about, and like, I rarely see prolapse, only because that's typical in like somebody that's had multiple childbirths or you're way older in age. I'll talk about really quick the two main things that I see, because I feel like they're more common for all of your listeners. So that's going to be stress incontinence and then urge incontinence. So there's kind of a difference between the two. So stress incontinence, again, is going to be those people that have leaking with running, coughing, sneezing. They have weakness of their pelvic floor. And we'll get into what a Kegel is next too, because I'm sure everyone's wondering what that is. And then more of the urge incontinence is when you feel this sudden urge to have to go to the bathroom, and you could be doing anything and you try to run to the bathroom really quick, but you didn't make it and you're leaking. So the big difference with urge incontinence is that can be weakness of your pelvic floor, but it can also be tightness of your pelvic floor. And no one thinks of pelvic floor dysfunction as, oh, they're too tight, which is actually pretty common in a younger female population rather than like a postpartum. So they lose that coordination. They don't have the coordination down. So, or they're chronically trying to pull their pelvic floor in literally all the time, and it's like any muscle in your body. Your pelvic floor is just like your hamstrings and your quads. It's a muscle. If you overwork it and you overuse it, it's going to get chronically tight. So that is really common too, that I see in young females that have like pain with sex because they don't know how to relax. So, and that can also be a learned behavior when it comes to urge incontinence. So maybe you go to the bathroom right when you go to work every day. So you've literally trained your brain and your body, I have to go to the bathroom at 8:05 when I walk into the office. So trying to not go to the bathroom unless you actually have to go, or if you feel that urge, you can stop, take a couple deep breaths, get your pelvic floor to relax, and do some Kegels, which I'll talk about cueing in a minute, to get yourself out of that, I have to go right now, or I'm not going to make it to the bathroom. So it's interesting because that's kind of a learned behavior. It can also be anxiety and stress induced, where you can develop urge incontinence. And then, like I said, the stress incontinence is more you actually have a weakness. So good little
that's
mix.
Like, I'm like, that name doesn't like those. That should be like the opposite, right? Like the stress incontinence should be like stress related, and then the other one shouldn't. But you know, it's fine. I didn't name it. Nobody consulted with us, but that's
stress. Think of stress as like body stress, like you're physically working out, or there's a cough or a sneeze, and there's intra-abdominal pressure, and your pelvic floor literally doesn't know how to activate, so you just leak.
That makes sense. But yeah, so I know we touched on it a little bit before, but like, okay, so regular PT obviously versus a pelvic floor PT. I know a lot of people listening are probably like, all right, well maybe this is what I need to, like maybe I need to go see somebody. You know, what would the pelvic floor specialist do, or, you know, what to look for in somebody who, you know, would a regular PT be able to do this? Would they not? Is it like a certification? Like,
yeah, totally.
Those questions.
So obviously all PTs have to get their doctorate, right? We go through 7 years of schooling. We do have a women's health section where we're taught, we have to know the anatomy extensively. We dissected it. And then we have a women's, at least at WashU, we had a women's health course. We were taught by two really amazing women that are actually women's health certified. They've changed the name in the last couple years from women's health to pelvic floor specialists. So you'll hear me say that more because they address both male and female issues. It's not just a female issue. So the big difference that I like to tell my clients, because obviously I'm not a certified women's health specialist, you have to sit for a board examination to do that. and that's a 7-hour test. So you work X amount of hours, and then you study and you take this test. So it's another certification that you can get. There are obviously tons of continuing education courses for women's health and pelvic floor. There's like level 1, level 2 certs, so you can do that as well. Now, the easiest way to find a specialist is actually, it's super simple. You would go to aptapelvichealth.org, and right at the top there's Find a PT. So you can search from your area, you can do a radius, whatever, 20, 30 miles. You can search by name if you know somebody to get their location, and then you can actually break it down by topic. So you can find somebody that works with bladder incontinence or stress incontinence or constipation or pain with sex, and you can find a provider near you that does that. They also are taught, so when you go through like your women's health certification exam, you do an actual internal exam. So they're gonna do an exam like you go to the OBGYN. They're going to palpate different muscles. It's nice because they can feel if they're too tight or not tight enough, like we talked about earlier. So that spectrum of, okay, is your pelvic floor dysfunction coming from you chronically stiffening everything up, or is it weak? So that's a good way. And like, I'll refer my clients out if I think they need a further examination where they're going to get an internal exam from a certified women's health specialist.
Yeah, I think that's definitely like the biggest difference, and that's like what I didn't know. So that is good to know. So if you are experiencing these things, expect an internal exam to be part of it if somebody is specialized in this area. Like you said, it doesn't have to be just like or is only somebody who's that board certified able to do that?
Typically only board certified. Well, not necessarily. So if you take the level 1 and level 2 courses for women's health through the APTA, which is just the American Physical Therapy Association, you get taught an internal examination. So you don't have to be board certified to do that.
But you do have to have those certs.
Yeah, you need to go through the courses, and they'll tell you, like, I don't think anyone's going to be like, yeah, I can do that, and I never learned, like,
well, you never know. So definitely want to give people the insights of what they should and shouldn't expect.
And if you go to a PT and maybe you're seeing a PT for like knee pain or hip pain or back pain, and you think
I need to do an internal exam.
You're like, wait, what? Are you certified to do that?
You're like, I'm a doctor, trust me. Yeah.
You can ask them like, oh, okay, did you do like a level 1 or level 2 cert? I'm telling you right now, like most physical therapists are not gonna just like blindly say, oh yeah, I'll do that without knowing what they're doing. Yeah,
there's I know there was like for the really low, like the sacral kind of issues, there's also an internal
pelvic
kind
floor
of adjustment. And people like have to deal with that as well. That's a whole separate issue, but so definitely we'll put that link in the show notes for people, so they'll be able to look up. And
super easy.
If you think that you're having any of these issues, it'd probably make the most sense, like we talked about in the beginning. Like, you want to get the most out of your sessions, right? So just going to regular PT might not be a bad idea, right? But it might just be better, like, hey, let me really like hit this head on. Go to a specialist.
That's why they get their board examination and take it. Like, find somebody that's going to specialize in pelvic floor health. That's what I would recommend.
And then Kegels. Let's
talk about Kegels.
So they are, I would say, those are probably the most common things when people are like, oh, pelvic floor health, must do Kegels.
Funny story. There's actually this lady on Instagram. I don't know if you've seen her. I have to think of her name. I'll have you put it in the show notes. But she literally does Kegels with like massive weights hanging from her vagina. I'm not even kidding.
I'm serious. Not what I was expecting.
So talk about Kegel strength. Okay.
Wow. Yeah, that's impressive.
Wild. She'll like hang like rocks. I'm serious.
Anything for Instagram,
I'm
right?
serious. Like, it's crazy. She's been doing it for years.
But maybe she really does. Like, she needs the progressive overload.
It's nuts. I'm telling you, it's like a muscle in your body. You gotta train it, right?
Wow.
So the infamous Kegel, or pelvic floor contraction, you can call it either one, right? The technical term is just pelvic floor contraction, but somehow we came up with Kegel. So what that is going to be is, especially for somebody that's postpartum or has a weak pelvic floor, that's going to be beneficial for you. Obviously, we're going to incorporate it with breath, because you guys know that's the number one thing. If you take one thing away from the show today, learn how to breathe correctly, and then incorporate it with your Kegels. So I like to cue people a couple different things. Number one, do not think of squeezing. We talked about your pelvic floor anatomy. It's like a hammock, or you can think of it as a trampoline. You want it to be nice and elastic, okay? So a weak pelvic floor, think of a trampoline that's broke, okay? So the goal with a Kegel is as you exhale, because we know that pelvic floor is closely related to your lower abdominals, you want to think about lifting, not squeezing. I think it's easiest to learn in the sitting position or in hands and knees position, because if you're sitting, you can think of that hammock or that trampoline underneath you and have it lift. Another thing to think about is if you're sitting on a coffee bean or a blueberry and you have a straw in your vagina, I know this is weird, but it works. Think about gently lifting that blueberry or coffee bean up and in as you exhale. Again, do it with your breath work, okay? That's kind of like the overview of it. I will say I try to ask people like where they feel it, because it's really easy to only feel it, say it in the front or the back. But again, we know that anatomy, it covers everything from your vagina to your rectus. So you need to feel it everywhere, front, back, side to side. That whole entire hammock muscle needs to lift up and in. So when you do a Kegel, you want to think, again, just gently lifting everything up. And you can kind of vary it, because we know it's a muscle, so it needs to have type 1, type 2 fibers, right? So you want fast twitch contractions. For instances in somebody that has stress incontinence and they're running or they're jumping, you need to be able to quickly perform those contractions to help hold it in. So you can kind of test out your endurance of that muscle. You can do slow contractions where you try to bring it up and hold it. You can do fast twitch contractions where you're doing like 5 in a row and then relaxing. And then off of that, so spinning off of that, that's that contraction. You want to be able to relax it. So the pelvic floor dysfunction we talked about earlier, where everything's tight because you're constantly pulling it up, you can do something called a reverse Kegel, where you're actually just working on inhaling, using that diaphragm, letting your belly come out, and then literally relaxing everything down there. So not doing any type of contraction of your pelvic floor.
So I was going to say, that was my question, like, is this good for both types of incontinence or just one or the other?
Yeah, so it can be used for both. So the inhale, when you're relaxing everything and not contracting, is just as important as the exhale when you're going to try to lift that pelvic floor up in it. So again, think of that coffee bean, that blueberry, you're trying to lift, not suck. Some people think they need to squeeze too, so I don't like that terminology. You really think of just lifting up and in.
Okay. Yeah, that makes it like that visual. It is like a weird visual, but it like makes perfect. It makes perfect sense. Anything else with pelvic floor that you feel like is like a very common?
We talked about Kegels, lower abs, breathing. I really can't recommend this enough. Like, if you're pregnant, it is safe to go to a pelvic floor specialist too, and sometimes they'll even do an internal exam after the first trimester. I really, really recommend going to see a specialist. Ask your OBGYN, advocate for yourself, because like I said, in Europe even, that's what they do. Naturally, they go see a specialist. That's not what happens here in America. You have your baby and then 6 weeks later you're expected to just go back through your normal daily life and get back to working out. And things don't feel the same and they feel weird and you have postural changes. So recommend really seeing a physical therapist or a pelvic floor specialist to help you get back to what you want to do and to achieve your goals, but to do it safely. So and then I know I kind of touched upon this earlier too, I can't talk about posture enough. It's really a mixed thing in the rehab and fitness where like some people are like, oh, who cares about posture? I truly believe you should be able to move in and out of any type of posture safely and not have pain, but when it comes to your pelvic floor and using your lower abs, you have to be in a good posture to do that. So taking breaks throughout the day, finding a wall, getting your back nice and straight, learning to get your rib cage stacked over your pelvis, your shoulders back so you're not in this like forward head posture or super anteriorly tilted with a lot of compression in your low back, or even that sway back posture that you can get into a bad habit of when you're breastfeeding because you're in this awkward position. And then early on, like postpartum, we know there's still hormonal changes happening. So I like to cue moms, like, don't do a lot of unilateral things. Keep everything symmetric. When you're breastfeeding, when you're picking up your kiddo, switch sides so that as you continue to gain strength and kind of work on those muscle imbalances, you do it so safely.
Nice. Yeah, I think that's all really, really great tips. We will link that site for the specialists below. And then also you said you have a practice here in St. Louis.
Yes.
So anybody who is local to the area, we'll put your information there. And you also do online consults as well.
Correct.
So just talk a little bit about that.
Yeah.
What types of clients would maybe benefit from that?
Yeah, totally. So I have my practice here, like I said, I see a wide range of people. I see everything from professional athletes to 12-year-old kiddos and everything in between. And then online, I feel like it's more appropriate for somebody that's maybe having some knee pain with squatting or deadlifting, or maybe you're having some leaking with activity and you want to learn how to use your pelvic floor, how to get back to squatting without back pain. So I do movement. I call it a movement assessment, and it's all done via Zoom virtually. Typical assessments are an hour, and then I use an app to train to use for programming specifically. So once we do that assessment, we educate, because I'm really big on that, and correcting movement faults, and I develop a program for you to basically do, and we'll check in and we can do follow-ups. So I prefer in person, but virtual is great too, and I really learned to do that throughout this whole pandemic, and it's been awesome getting to see people make changes and never having met them in person. So
yeah, and
I mean,
I run an online business, so I understand like there's so much that can be done in a face-to-face setting. I mean, especially for like what you're doing.
Yes, totally.
And there's no way that you can replace that with online, but it is really cool to be able to, potentially impact people all over.
Yeah.
And yes, I'm really happy that you have that option. So we'll put your contact information below in the show notes as well. So yeah, thank you so much. This was great.
Of course. I'm so excited.
I hope this kind of cleared up maybe some misconceptions or just really like misunderstandings about like what it is. And yeah, so thank you guys as always for listening, and we'll talk to you next week.
Bye guys.